Lateral Epicondylitis. Tennis elbow. Kamal Gokuz. Associate Professor. Tashkent University Alanya Research and Practice Center. This video was produced from the book source that was shown below. Boy Martin Israel. 2014. Aus Comprehensive Orthopedic Review 2. American Academy of Orthopedic Surgeons. Acknowledgement. We would like to acknowledge the editor Boyer Martin and chapter author John Eric Bell, MD, in preparing the text of this chapter in the previous edition. Citation. Boyer Martin Israel. 2014. Aus Comprehensive Orthopedic Review 2. American Academy of Orthopedic Surgeons. Overview and epidemiology. Lateral epicondylitis is the most common cause of elbow pain in the general population. It affects 1% to 3% of adults annually. It is most common between the ages of 35 and 50 years. It occurs most commonly in the dominant arm. Men and women are affected equally. Lateral epicondylitis affects 10% to 50% of recreational tennis players. A. Risk factors include poor swing technique, a heavy racket, incorrect grip size, and high string tension. B. Lateral epicondylitis is typically caused by eccentric contractions of the extensor carpi radialis brevis, ECRB, muscle during the backhand swing. 3. Lateral epicondylitis is also a common work-related injury, seen in persons with a history of manual labor with heavy tools and persons engaged in repetitive gripping or lifting tasks. Anatomy and pathoanatomy. Relevant anatomy, Figure A. The pathology is primarily localized to the ECRB origin. B. The brachioradialis and extensor carpi radialis longus, ECRL, originate more proximally on the humerus than does the ECRB. C. The ECRB and extensor digitorum communis, EDC, have tendinous origins and lie deep to the ECRL, which has a muscular origin. D. The common extensors lie superficial to the lateral collateral ligament complex proximally and to the supinator distally. The ECRB tendon lies superficial to the joint capsule and is therefore accessible arthroscopically. F. The posterior interosseous nerve enters the supinator distal to the radial head. Compression at this site, the radial tunnel, can coexist with lateral epicondylitis. Illustrations show the anatomy of the common extensor tendon. A. With the capsule removed, the anatomic relationships of the common extensor tendon can be seen. B. Intra-articular perspective of the common extensor tendon insertion on the lateral humeral epicondyle. C equals capitellum, RH equals radial head, ECRB equals extensor carpi radialis brevis, EDC equals extensor digitorum communis, ECU equals extensor carpi ulnaris, ECRL equals extensor carpi radialis longus. Reproduced from Baker C. L. Jr., Arthroscopic Release for Lateral Epicondylitis, in Yamaguchi K., King G.J.W., McKee M.D., O'Driscoll S.W.M., eds., Advanced Reconstruction, Elbow. Rosemont, Illinois, American Academy of Orthopedic Surgeons, 2007, pages 25 to 30. Histology. A. The primary lesion of lateral epicondylitis is classically found in the origin of the ECRB, but it can also be seen in the EDC. B. Histologic studies show what Nerschel termed angiofibroblastic hyperplasia, Figure C. Findings include neovascularization, infiltration by mucopolysaccharide, a disordered collagen scaffold, bone formation, and angiofibroblastic proliferation. D. Inflammation is not usually seen but is likely in the early stages. E. The lesion occurs in a vascular watershed area that is relatively avascular, limiting healing potential. Evaluation. History. The onset of symptoms is typically atraumatic. Symptoms often develop secondary to repetitive wrist extension, but they can also be insidious, without an obvious cause. Pain is localized to the anterodistal aspect of the lateral epicondyle, with occasional radiation to the forearm. Heavy gripping, lifting, especially palm down, and repetitive wrist extension increase symptoms. Differential diagnosis. Posterolateral plica. Posterolateral rotatory instability. Radial tunnel syndrome. Posterior interosseous nerve compression coexists with lateral epicondylitis in 5% of patients. Occult fracture. Cervical radiculopathy. Capitellar osteochondritis dissecans. Triceps tendinitis. Radiocapitellar osteoarthritis. Shingles. Physical examination. Tenderness to palpation, which typically is very focal, is found at the anterodistal aspect of the lateral epicondyle, origin of the ECRB. Resisted wrist extension with the forearm pronated recreates symptoms at the elbow, which are worse with elbow extension than flexion. Passive wrist flexion in pronation causes pain at the elbow. Decreased grip strength may be noted. Radial tunnel examination includes palpation of the radial tunnel, 3 to 4 cm distal and anterior to the lateral epicondyle, pain with resisted third finger extension, and pain with resisted forearm supination. Physical examination. Evaluation for intra-articular sources of pain. Passive flexion of the elbow in pronation and supination elicits pain and palpable clicking of the posterolateral plica. Intra-articular injection of corticosteroid medication relieves pain. Examination of the cervical spine, including the Sperling sign, should be done because a C6 radiculopathy can mimic lateral epicondylitis. Imaging. Radiography. Plain radiographs may reveal calcifications in the extensor muscle mass, present in up to 20% of patients. They may also reveal problems caused by previous surgical treatment, excessive debridement of the lateral epicondyle or epicondylectomy resulting in posterolateral rotatory instability, PLRI. Imaging. Magnetic resonance imaging. Pathology of the ECRB origin, thickening, edema, tendon degeneration, is seen on MRI in up to 90% of cases. Similar findings are also seen in 14% to 54% of asymptomatic elbows, but they do not correlate with symptom severity, and they should not be used as an indication for surgery without a positive physical examination. MRI is not necessary for the diagnosis of lateral epicondylitis, it is more useful for finding other sources of pain. Ultrasonography requires an experienced operator. The ECRB tendon appears thickened and hypoechoic on ultrasonography. Has variable sensitivity and specificity. Ultrasonography is most useful in diagnosing lateral epicondylitis when used regularly and by experienced operators. Treatment. 1. When lateral epicondylitis is an isolated diagnosis without clearly symptomatic intra-articular pathology, non-surgical treatment should always be tried first. A. Activity modification. B. NSAIDs. C. Physical therapy has been shown to be 91% effective at 52 weeks. D. Injection. Corticosteroid injections are most helpful for the short-term relief of symptoms. They do not improve the long-term outcome, however, and in some studies are associated with worse long-term results. Treatment. Botulinum toxin may work by temporarily paralyzing the extensor wad, decreasing tension on the ECRB origin. Randomized controlled trials of botulinum toxin show mixed results. Autologous blood and platelet-rich plasma can also be used. These techniques are frequently used, but the literature on their efficacy is mixed and there is no definitive evidence for their superiority over corticosteroids or placebo at this time. Treatment. Bracing may work by reducing tension on the extensor origin. Cock-up wrist splint blocks contraction of extensors. Counterforce brace, band compression over the muscle belly unloads the extensor origin. No definitive evidence shows that the cock-up wrist splint or the counterforce brace has superior outcomes compared with the other. Likewise, no definitive evidence shows that bracing is effective in improving the symptoms of tennis elbow, although braces are commonly used. Acupuncture. Iontophoresis/phonophoresis. Extracorporeal shock-wave therapy. No definitive evidence exists to show the effectiveness of EXT. Recent prospective randomized trials have produced conflicting results. Treatment. Bracing may work by reducing tension on the extensor origin. Cock-up wrist splint blocks contraction of extensors. Counterforce brace, band compression over the muscle belly unloads the extensor origin. No definitive evidence shows that the cock-up wrist splint or the counterforce brace has superior outcomes compared with the other. Likewise, no definitive evidence shows that bracing is effective in improving the symptoms of tennis elbow, although braces are commonly used. Acupuncture. Iontophoresis/phonophoresis. Extracorporeal shock wave therapy. No definitive evidence exists to show the effectiveness of IXT. Recent prospective randomized trials have produced conflicting results. Surgical treatment. Indications for surgery include the following: persistent symptoms despite 6 to 12 months of non-surgical treatment. A clear diagnosis: isolated lateral epicondylitis. Intra-articular pathology, incidence ranges from 11% to 44%. Contraindications to surgery include the following: inadequate trial of non-surgical treatment. Patient non-compliance with the recommended non-surgical treatment. Surgical treatment. Open treatment. The incision is positioned over the lateral epicondyle. The common extensor origin is sharply incised. The ECRL muscle must be elevated off the ECRB, which is located deep and slightly posterior to the ECRL. Degenerative, disorganized tissue is excised. The epicondyle is decorticated. If the capsule is breached, it is repaired. Side-to-side closure of the superficial tendon is done. Surgical treatment. Arthroscopic treatment. Arthroscopic treatment allows an increased ability to visualize and manage intra-articular pathology. The lateral capsule is resected anteriorly no farther than the mid-radial head to avoid injuring the lateral ulnar collateral ligament. The origin of the ECRB is released to the point at which the muscle tissue begins. The lateral epicondyle can be decorticated with a burr. Results of treatment. Improvement is reported with both open and arthroscopic techniques, with mostly good and excellent results, but many patients have persistent symptoms. Open treatment results in improvement of symptoms in 94% to 97% of patients, but many continue to have symptoms after surgery, 24% at 1 year. Arthroscopic treatment appears to be beneficial, with 93% to 100% of patients better or much better at a mean of 2 years postoperatively. Nevertheless, 20% to 38% of patients continued to have persistent lateral elbow pain. Complications. 1. Lateral ulnar collateral ligament injury, results in posterolateral rotatory instability. 2. Nerve injury, more common with arthroscopic release. 3. Heterotopic ossification around the epicondyle. 4. Infection. 5. Missed concomitant pathologies, such as posterolateral rotatory instability or radial nerve entrapment. Pearls and pitfalls. 1. Surgery is rarely required with adequate non-surgical treatment and reasonable patient compliance. 2. If surgery is indicated, management of patient expectations is critical because improvement can occur without complete symptom relief. 3. Familiarity with the anatomy of the lateral ulnar collateral ligament and its relationship to the epicondyle, radial head, and extensor carpi radialis brevis origin allows the surgeon to avoid iatrogenic posterolateral rotatory instability. 4. After decortication, thorough removal of bone fragments by irrigation may decrease the risk of heterotopic bone formation around the epicondyle. Top testing facts. Lateral epicondylitis. The lesion of lateral epicondylitis is typically found in the origin of the extensor carpi radialis brevis. Nerschel termed the histologic lesion angiofibroblastic hyperplasia. Differential diagnosis of lateral epicondylitis includes radial tunnel syndrome and radiocapitellar plica. PA and lateral radiographs are usually normal. Non-surgical treatment is attempted initially and is usually effective. Surgical injury of the lateral ulnar collateral ligament results in iatrogenic posterolateral rotatory instability of the elbow. Thank you for watching my video. Please subscribe to my YouTube channel.